Hi, thanks for watching. This is Nurse Inga, and we're going to talk about eating disorders. The vocabulary that we use for eating disorders is very specific to mental health, stress, and anxiety as it relates to the manipulation of food. Anorexia is the loss of appetite, and drugs that suppress the appetite are called anorexiants. Anorexia nervosa is a condition where there is a morbid fear of obesity in someone who is usually underweight, and they have a gross distortion of body image, usually a refusal to eat. They oftentimes experience amenorrhea, which is a cessation of menses after the onset of menarche, and this usually occurs either from pregnancy, medication, or a 25% or greater loss of body fat. They oftentimes appear emaciated, which is excessively thin or wasted. Alternatively, we have bulimia nervosa, which is characterized by binging and purging in order to achieve a culturally ideal body weight. There's also binge eating disorder, or BED, where the person binges without purging. Binging is defined as the rapid ingestion of a large quantity of soft, sweet, smooth, high-calorie food over a short period of time. And purging is a self-induced kind of activity to rid the body of calories, such as vomiting, laxative or enema use, diuretics, and excessive exercise. Obesity is defined as a BMI of 30% or greater. Let's explore some of the eating disorders in more detail. Anorexia nervosa impacts women between the ages of 12 and 30 years old. About 1% of the U.S. population has been diagnosed with anorexia nervosa. These women usually have a BMI that's less than 17%, but they have a morbid fear of obesity and a grossly distorted body image. They see themselves as fat, even though usually they're emaciated. They're preoccupied with food, and they refuse to eat. They do have hunger. They are not anorexic. They have not lost their appetite, but they refuse to feed themselves. They also attempt to lose weight through purging, so decreased PO, increased exercise, but they do not binge. Side effects of developing anorexia nervosa include hypothermia, bradycardia, hypotension, edema, the development of lanugo, amenorrhea, and delayed psychosocial development. And most of these are related to a decrease in body and muscle mass. They display an obsession with food. They love to hoard food, conceal food, talk about food, and prepare food for others. They also may exhibit some compulsive behaviors, such as hand washing. Obsessions are thoughts, and behaviors are compulsions. Depression and anxiety are common in this population, and many patients who have anorexia nervosa also demonstrate signs and symptoms of affective disorder. There are different influences. 56% have a family history or a genetic link. In our book, it talks about neuroendocrine disorders, neurotransmitters, imbalanced, like psychodynamic problems. And oftentimes there will be some sort of an altered family process or a problem at home where there's conflict. Parents will use food as a punishment or reward system. Children will attempt to gain control of a situation by refusing to eat. Conflict is avoided, and they see this as a power and control issue. Common nursing diagnoses for patients with anorexia nervosa include imbalanced nutrition, less than body requirements, deficient fluid volume, ineffective denial, disturbed body image, low self-esteem, anxiety, and altered family process. Our goals are to aid in behavior modification, and that includes contracting for privileges based on weight gain, and the goal would be to gain roughly 2 pounds per week. If the client eats or gains weight or demonstrates the ability to recognize anxiety and triggers and demonstrates healthier coping mechanisms, then they are developing a sense of autonomy and control in a different fashion, and we reward those behaviors. Therapy can be both individual and family oriented, and the medications such as SSRIs and tricyclic antidepressants are oftentimes helpful. There's no specific medication for eating disorders, but medications that control depression, anxiety, and OCD can help, and medications that stimulate the appetite can also help with the symptom control. If the patient has opiates on board, Narcan will help reverse the effects of appetite suppression from the opiates. A related eating disorder, bulimia nervosa, occurs more often in 4% of young women. This is very cultural and is usually seen only in developed countries where food is abundant and where the emphasis on beauty is being thin. These women typically have a normal to slightly elevated BMI, and they alternate between episodes of binging and purging. Binging is the rapid consumption of high calories, sweet taste, soft, smooth textured food. They may consume it so quickly that they don't even chew it. Typically, this is eaten rapidly in private or secret. The urge to stop binging only occurs when the patient develops pain, falls asleep, is interrupted, or needs to self-induce vomiting. The binge itself brings pleasure. Sugar releases serotonin, followed by a sense of self-degradation and loathing, depression and guilt. The purge is an obsession with removal of the consumed calories. The patient may use medications such as emetics, laxatives, diuretics, or enemas, or they may even stick their finger down their throat to induce vomiting. All of this in an effort to empty the GI tract and reduce the amount of calories absorbed. They may fast or follow a very strict diet for a period of time, or use excessive exercise to burn off those bad calories that they consumed. They tend to be over-concerned with personal appearance, and their weight often fluctuates. They're at risk for electrolyte imbalance and dehydration from the vomiting, and erosion of tooth enamel and fingernail discoloration from the contact with the stomach acids. Often they will have related mood, substance abuse, or anxiety disorders. The links for genetic and psychodynamic influences are the same as with anorexia. Priority nursing diagnoses for bulimia nervosa include deficient fluid volume, at risk for imbalanced nutrition, and that could be more or less than body requirements, ineffective denial, disturbed body image, low self-esteem, and anxiety. Therapy is often helpful, and medications such as SSRIs and TCAs are used for bulimia nervosa to treat the underlying mood disorders, just like with anorexia. This is the cycle of bulimia. Tension and cravings increase stress and anxiety. The person binge eats to stimulate serotonin release and feel better, and then has purging to avoid weight gain and a sense of shame and disgust, so they start strict dieting. and they feel in control for a little while, but then the tension and cravings build back up again, and they binge eat, purge, feel terrible, diet, get stressed out, binge eat, purge, feel terrible, diet, and so on. There is also a disorder called binge eating disorder, or BED, where the person develops morbid obesity, so their BMI is high, from binge pattern eating without any purging or attempt to rid the body of calories. Obviously, if you eat much more than you take in, this will cause obesity. We know that obesity is linked to hypertension, hyperlipidemia, elevated glucose, diabetes, osteoarthritis, coronary artery disease, and respiratory diseases. Unfortunately, the stimulant medications that are used to treat binge eating disorders that are anorexiants, so medications that are used to decrease appetite, are often unsafe for this population because they already have heart disease, which could lead to ischemia or myocardial infarction or stroke. So some overriding goals with all eating disorders. Our primary goal is weight management. We want a change of 2 pounds per week in the desired direction. So the patient with anorexia nervosa should be gaining 2 pounds per week, and the patient with binge eating disorder should be losing 2 pounds per week. And depending on the weight of the patient with bulimia nervosa, they may be needing to stabilize or they may be needing to gain or lose. This is accomplished through alleviating anxiety and managing stress. So we want to give them the tools to utilize, which would include some healthy coping mechanisms. They should be able to recognize what causes their anxiety and their stress. This will return a sense of self-control and help them feel successful. When you think about the underlying cause of many of these eating disorders, it's a lack of control, and it's an attempt to feel in control of some area or aspect of their life. So teaching them how to be in control helps. We want to remove the focus from meals and food. If we're always talking and obsessing about food and meals, then the focus is going to stay on food and meals, and it's going to be hard for them to start focusing on other activities or aspects that could manage their stress. So really we want to think about alleviating anxiety, managing stress, healthy coping mechanisms, and putting them at the wheel. Our nursing interventions should include remaining with the client during and 1 hour after meals to watch for eating habits while they're eating, and then binging, purging, and avoidance to make sure that they're actually eating and keeping things in. And positive reinforcement really means empowerment. So if the client gains the weight, or if the client is eating, and if the client is demonstrating adequate coping mechanisms and a good sense of self-control, then they should earn rewards within the unit. And if they're not, then they chose not to do those things and they would lose those rewards. So really this positive reinforcement and an empowerment tool helps enforce even more the fact that they're in control and that they're in control of their success, and it helps drive them even further. That is the quick down and dirty on eating disorders. Thank you for watching.